So this is our third installment of antivirals for hepatitis C virus. Our objectives here are again to list the antiviral drugs approved for HCV therapy, describe the mechanism of action of each antiviral drug class because we have more than one class available to us, identify significant drug interactions for each antiviral drug, identify the major toxicities of each drug, and development of resistance. I'm showing you here the Child-Turcotte-Pugh score, which is a means of assessing chronic liver disease. So the measures that are involved are total bilirubin, serum albumin, prothrombin time, ascites, and hepatic encephalopathy. And these are all measured and graded and given point values, which are summed, and then the sum of those points determines what grade you end up with. So 5 to 6 points describes a mild, well-compensated infection, and that's grade A. And then as we get significantly more functional compromise, we go to grades B and C. So the reason I give that to you is it's mentioned in choosing antiviral therapy as to whether a patient can tolerate certain combinations. Now, historically, HCV was treated by a combination of pegylated interferon and ribavirin. And this was the only therapy that was available for HCV disease. What happened was there were low response rates for some of the HCV genotypes. There's 6 of those, and in particular genotype 1, which is the most prevalent in the United States. So go back to the HBV antivirals that we talked about and look up the information we talked about for interferon toxicity and contraindications for use, because this is now not being used in therapy. But ribavirin, which was the other component, continues to be used in some of the recommended direct-acting antiviral combinations, or DAAs, which are regimens without interferon. It has activity against all the HCV genotypes, which we call pan-genotypic. It has been used to treat severe pediatric respiratory syncytial virus infections and for treatment of other RNA viruses off-label, such as Lassa fever or parainfluenza hantavirus. But we don't have approval necessarily for the use for those viruses and no really conclusive data that they are useful. It's just that these are very infectious, serious virus infections, and so people are looking for whatever they can try to treat with an antiviral. This is a synthetic purine nucleoside analog, but the actual mechanism is somewhat unclear. It seems to cause depletion of intracellular purines such as GTP and inhibition of protein synthesis, as well as inhibition of the HCV RNA polymerase. It's given orally in 2 doses, and this is weight-based. So there's a cutoff of 75 kilograms, and patients below that weight get 1 dose, and those above that weight get another dose. It's also administered by aerosol for RSV treatment. It interacts with HIV nucleoside analogs listed here, lamivudine, zadovudine, and adenosine. Causes pancytopenia when it's co-administered with azathioprine. One of the more toxic complications is hemolytic anemia, which occurs with systemic administration and may lead to worsening of an underlying cardiac disease secondary to severe anemia. Causes nausea, lethargy, headache, increased bilirubin, and uric acid. And it is a significant teratogen, so it is absolutely contraindicated in pregnancy. And that includes both the pregnant women and the male partners because the drug has been detected in semen. And then, of course, it's contraindicated for patients with significant or unstable cardiac disease. So our goals long-term for therapy for HCV, first of all, interferon-free regimens. Well, we've got that now. Combination drugs targeting multiple viral functions, and this leads to reduction of resistance, and you'll see that we have that. Single oral dose given once a day, and it contains the drug combinations. You'll see we have that. Pan-genotypic activity so that we don't have to genotype the virus strain from the patient. that occurs now. And then finally, a sustained virological response. And this is defined by treatment for 12 to 24 weeks, stopping treatment, waiting 12 weeks, and then looking to see if you can detect the virus. If you cannot, then it's considered a sustained virologic response. And as with HBV, I'm giving you the link to the guidelines. It's again from the ASLD, and it gives up-to-date treatment recommendations and combinations. So this is the HCV genome, and it shows the 3 targets. First, the NS3A4A, which is a protease inhibitor, NS5A inhibitors, which inhibit a gene that we don't know exactly what it does, but it's a very good target for antivirals. And then NS5B, which is the RNA polymerase. So there's kind of a hint that you can use to determine the activity of a given drug from the name of the drug. So if it ends in pravir, such as glucaprevir, it's a protease inhibitor. Asvir, such as ladipasvir, it's an NS5A inhibitor. Buvir, such as sofosbuvir, is an NS5B or RNA polymerase inhibitor. So we have 3 targets. So I'm going to go through the drugs, and I'm also going to give you the commercial names, which I usually don't do, but I'm noticing occasionally there are articles that talk only about the commercial name and don't give the common name. And so you don't need to memorize that, but maybe just maybe recognize it if you happen to see it. I'm sure on step 1 that it will not be the commercial names given. So for indications, sofosbuvir is pan-genotypic, so it has activity against all 6 genotypes. It's a nucleotide analog, so it has a phosphate group attached to it, and it does inhibit the RNA polymerase. It's also a prodrug, so it has to be converted after it's ingested to the active drug. And we've seen that we have several prodrugs among antivirals that we've been discussing. It's given once daily orally. It's a substrate for the P-glycoprotein, which is a drug efflux pump, pumps drugs out of cells. So it should not be given with inducers of P-glycoprotein, because that may end up lowering the sofosbuvir level. And I'm giving you examples of drugs that might be inducers. Whenever I give you these lists of drugs, they're almost always not exhaustive. There are many other drugs that have the same activity. I'm just giving you some examples. It's generally well tolerated, and a big plus is it has a high genetic barrier to resistance. Decladisvir is an NS5A inhibitor, which is used with sofosbuvir for genotypes 1, 2, and 3. And sometimes they throw in ribavirin for genotype 1 in patients with cirrhosis. It's given once daily with sofosbuvir, so we actually have 2 tablets that are given, not just 1, but it's only once a day. It's an inhibitor of P-glycoprotein, increases the level of drugs that are substrates for P-glycoprotein. It's also a substrate for CYP3A, which is a cytochrome oxidase involved in drug metabolism, and requires dose adjustments for strong inhibitors or moderate inducers of CYP3A. And here are a couple of examples. It causes fatigue, headache, nausea, diarrhea, but more importantly, serious bradycardia when it's co-administered with sofosbuvir and amiodarone. There are resistance mutations which appear to be genotype dependent and cause cross-resistance to other NS5A inhibitors. So we're again now with the combination drugs. What's happened with the companies, if they have drugs that have more than 1 target, they combine them. What happens then is you have a fixed dose combination, so you can't vary the dose of either drug, and you can't mix and match drugs from different companies, which is kind of a pain. But here we have sofosbuvir with ladipasvir, and that combination is known as Harvoni. And that name you might want to keep in mind, because that's been used commonly for quite a while now. It's indicated for HCV genotypes 1, 4, 5, and 6. Ladipasvir, from the name, is an NS5A inhibitor. The combination is given once daily. There is interaction with P-glycoprotein, so that substrates for P-glycoprotein, And inducers of P-glycoprotein can cause problems in the level of the drugs. It causes fatigue and headaches, and it has a high genetic barrier to resistance, which is good. So Ombidosphere, paritaprevir, and ritonavir are a fixed combination that's co-packaged with tisabivir as by Curopac. And because, as you can tell, we're already talking about a couple of pills, this combination probably is not going to be on the market within the next couple of years. And it's also combined sometimes with ribavirin, so we've got another pill here. And it's approved for treatment of chronic HCV genotype 1A infection if there's no or mild cirrhosis or CTP class A, and without ribavirin for genotype 1B. So Ombidosphere is an NS5A inhibitor. Paritaprevir inhibits the protease. Ritonavir has no HCV antiviral activity. So the reason it's included is it has strong inhibition of CYP3A, and that allows a higher concentration of other protease inhibitors that are co-administered. So in this case, paritaprevir. Ritonavir actually does have anti-HIV activity, but it is also used as a booster in HIV regimens that have other protease inhibitors. And then finally, tisabivir is a non-nucleoside inhibitor of NS5B RNA polymerase. And when I say non-nucleoside, that means it doesn't have the normal structure of a nucleoside or nucleotide. It binds allosterically elsewhere on the polymerase and affects the conformation of the active site so that you don't get further nucleotide addition, but it doesn't have the same cross-reactivity with the other nucleoside or nucleotide activities. You'll come across that non-nucleoside inhibitor term again with the HIV antivirals. It's given once daily as the combination, and then twice daily for the combination with tisabivir. It's not recommended or at least contraindicated with moderate or severe hepatic impairment, such as CTP class B or C. It interacts then with drugs that are highly dependent on CYP3A for clearance or strong inducers of CYP3A and P-glycoprotein. And this is a non-exhaustive list of some of those drugs. Causes fatigue, asthenia, nausea, insomnia, pruritus, other skin reactions. And it's a serious problem if there's underlying liver disease. As I mentioned, it is administered with ribavirin. So check back with the ribavirin complications above. And then resistance mutations have been identified, so we can expect cross-resistance with drug classes of the NS5A inhibitors or the protease inhibitors. So we have velpatasvir with sofosbuvir. Again, this is pan-genotypic. Velpatasvir is an NS5A inhibitor. Sofosbuvir is an NS5B polymerase inhibitor. They're given daily dosing as a single tablet. Both of these drugs are substrates for P-glycoprotein, and velpatasvir is actually also an inhibitor of P-glycoprotein. It should not be given with drugs that are inducers of P-glycoprotein because it may end up lowering then the sofosbuvir level. And then co-administration with amiodarone produces serious bradycardia. Complications or adverse events that are recorded are headache and fatigue, and you get resistance detected in cell culture, but cross-resistance to NS5A class drugs have not yet been determined. So then we have the same combination adding voxeloprevir. So this is pan-genotypic. Voxeloprevir is a protease inhibitor, so now we have drugs that target all three of our viral targets. And we get daily dosing of a single tablet that contains all three drugs. All the drugs are substrates of P-glycoprotein, and velpatasvir is an inhibitor of P-glycoprotein. It's contraindicated with inducers of P-glycoprotein or strong inducers of the CYP enzymes. And here's a short list of some of those drugs. It's co-administered with amiodarone, and when it is co-administered with amiodarone, it produces serious bradycardia. And it also interacts with HIV antiretrovirals, such as atazanavir, lopinavir, ritonavir, and tenofovir. And remember, tenofovir is also used for HBV. We have headache and fatigue and resistance detected in cell culture. Another combination is elbasvir and grazoprevir. It's recommended for genotypes 1 and 4. Elbasvir, as you might tell from the name, is an NS5A inhibitor. Grazoprevir is a protease inhibitor. And it's given once daily orally, not recommended for CTB classes B or C. Both the drugs are substrates of CYP3A enzymes. So they interact with moderate to strong CYP3A inducers or inhibitors. So that's going to affect your concentration of the drugs. Causes fatigue and headache. And it's recommended that you test for NS5A resistance mutations before starting therapy. And the reason for that is that HCV is replicated by an RNA polymerase, which makes a lot of mistakes and doesn't have any proofreading function. So what happens is resistance mutations can arise spontaneously during replication without exposure to drug. So you want to test to make sure that those are not present before you start therapy. Glecaprevir and preventosvir, this is the latest combination that's been approved. It's pan-genotypic. Glecaprevir is a protease inhibitor. Preventosvir is an NS5A inhibitor. It's given as 3 tablets of the combined drug. So each tablet has both drugs, but you take 3 of them once daily. And it's not recommended for CTP class B or C. Both drugs are inhibitors of P-glycoprotein and substrates of the CYP3A enzymes. They're interact with moderate to strong CYP3A inducers or inhibitors, and short list is given for each of these. They cause fatigue, headache, nausea, and diarrhea. So to summarize HCV, remember our original therapy was a combination of interferon ribavirin, but the problem was that only about 50% of infections of genotype 1 responded to this therapy. So now, with a lot of effort, we have interferon-free regimens using directly acting antiviral drugs. And we have 3 viral targets: the protease, NS5A, which is a replicative enzyme of some kind, and NS5B. We still have to consider the genotype in our choice of drugs, but this may eventually go away. And we also have to be careful of the level of fibrosis cirrhosis, which is based on the CTB score for the recommended regimens. We do have several pan-genotypic combinations: sofosbuvir and velpatasvir, those drugs plus boxilopravir, and then glecaprevir and preventosvir. So NS5B has a replicative enzyme of RNA-dependent RNA polymerase. So note that there's no DNA template involved, which is unlike HBV or HIV. They have protease activity that's similar to the HIV drugs, but there's no cross-reactivity. So a protease for HIV does not have any activity against a protease of HCV. And protease metabolism is important for drug-drug interactions, similar to what you'll see when you see the HIV antivirals. NS5A is a new target of approved drugs with an activity that we don't understand real well, but there's no homologous activity in HIV or HBV. Drugs with different targets and combination regimens are now available. So this allows us the potential for cure of HCV infection, even though we can have huge copy numbers in the blood. We have patients with 8 to 10 million copies of HCV walking around. So hopefully we're going to be able to cure that. And that's because there's no persistent or latent stage. Note also that the DAAs are never given as monotherapies. And that's because we have, first of all, that helps us because of the potential for resistance with an RNA virus. But also it's helpful in the fact that we have the luxury of multiple drug classes, which will keep down resistance. I've made a summary table of all of the combinations and some of the characteristics of each of those that might help you in a review. It also has a trade name, but do not memorize those. Memorize or learn the components that are present in the combinations. What the genotypes are. You don't have to memorize all the genotypes, so I would pick out the ones that are the pan-genotypic. Make sure that you know those. And note the pharmacology, interactions, and major toxicities. And this table is certainly for visual purposes. It's not to be tested, but what I wanted to bring up is the fact we have several of the HCV antivirals across here and other drugs that they might be on simultaneously to determine whether there might be interaction of the antiviral with these drugs. Note that wherever there's a protease involved, you have a lot of interactions. And this is true for HIV proteases as well. Notice with the sofosbuvir, which is the nucleotide analog, we have fewer interactions, and sort of intermediate with the NS5A inhibitors. So just get a sense for the fact that protease inhibitors tend to have a lot of drug-drug interactions.